Werner, and we are here at the Royal College of Psychiatrists International Congress 2019, and I have Professor Glyn Lewis with me today, who has just given a talk about antidepressants. So would you be able to tell us a little bit more about what you've just been talking about?
Yes, so we were discussing the effects of antidepressant, the benefits, and my particular talk was about how we might be able to use that information to decide whether someone should or shouldn't go on an antidepressant. So the core idea I was putting forward was the idea of a minimal, clinically important difference, because you could have a trial or a big meta-analysis like that of Andrea Cipriani's, where you can find statistically significant differences, but that doesn't mean necessarily it's a clinically important difference. So how can we decide whether you've just got a statistical result or whether it's actually going to benefit patients? So the idea of the minimal clinically important difference, MCID for short, is that it's the smallest difference that a patient would regard as being a benefit. So if we know that value, we can then use clinical trial results and say, well, on average, this drug or intervention leads to a difference larger than this MCID, therefore you're going to benefit from it on average. But so there are various ways of deciding on the MCID, or trying to estimate that. But the approach we've taken is to actually, in a revolutionary way, well, not at all revolutionary, is to actually ask patients. And so we asked them, do you feel better compared with when we last saw you? And then we can compare their responses on the questionnaires from the last time we saw them and find out what sort of difference corresponds to them feeling better.
Right.
And so when we first did this, we thought, oh great, we got the answer. It was about 5 points on the Beck Depression Inventory.
Right.
But actually it's a lot more complicated than that, unfortunately, because it seems that this MCID is much larger for those people who are scoring more on the Beck or any other questionnaire than those who are scoring less. So we then thought, well, let's use a percentage term. Maybe it's a percentage, and that does fit much better.
Okay.
So in terms of the sort of headline results, it seems that in general a 20% reduction on these depression questionnaires or anxiety questionnaires means that that person will think they're feeling better. But even that percentage rule seems to break down when people are very mild. And those mild things are actually quite important in primary care, because the way to use the MCID is almost to sort of project into the future. You've got to be able to say to patients, well, if you were on the placebo, I know you're going to be scoring X points in 6 weeks' time. And if I give you this drug, I know it's going to be X minus something else points. And so you've got to apply these differences to, if you like, these kind of futuristic predictions. So actually quite often some of the people that are treated in primary care are going to be in this range where they might actually be experiencing a treatment effect, but they can't tell whether they're better or not.
Yes. Yeah.
So that's really, and that's in a sense as far as we've got at the moment. That we've developed a way of trying to estimate the MCID. We've got a rough idea of what it is in percentage terms at the high scores, but we've still got a lot of work to do at the lower end of the range. And also we need to be able to predict what people are going to be scoring in the future so that we can then advise them about whether to take the treatment or not.
Yeah.
So we do have more to do,
Yeah.
but we think this might be a way of translating clinical findings into proper clinical guidelines.
Yeah, it definitely seems like it's that step in the right direction. I've heard a lot this week about the idea of individualising treatment for people, because mental illness is such a sort of wide spectrum, and it's not a kind of one treatment fits all. And it sounds like that's where this research is kind of heading, in terms of actually giving people treatment that's individualised to them.
Yes, that's right. So if somebody comes along and maybe we collect some information about them or plug it into some sort of app or whatever, we can say, well, we think if you're not treated, you'll be scoring 8 points, and if you are, that's 5 points. And that, as far as we can tell from all this evidence, is a clinically important benefit. So we'd say, take the medication.
Yeah.
Of course, at the moment, we haven't got any of the adverse effects or anything. In fact, some of the questions we were asked, well, what about discontinuation symptoms? Well, at the moment, we've got no way of putting that into that guidance. We can only say you will be better, but clearly those adverse effects have to be taken into account as well.
Yes, there's a lot more kind of to fit in there that makes it a lot more complicated.
Yes.
But what you're doing really seems to be kind of putting those steps in the right direction.
Well, that's our intention.
Yeah. How long do you think it would be before we were able to use an algorithm, like you said?
Well, I think what we're doing at the moment is we're using this question about do you feel better in our local IAP service.
Right. Okay.
And that should give us a lot of data, many thousands, maybe tens of thousands of people.
Yeah.
So using that data, I'm hoping we'll get a much better idea of what the MCID might be doing at these lower severity levels. And arguably IAP data can also be used to predict future scores as well. So I would see those steps as really coming from these big data sources such as IAP and other routine outcome measurement data sets.
Wow, yeah, that sounds really interesting. So I look forward to hearing kind of the outcome of that once you get the results from the IAP that you're doing. Thank you so much for speaking to me today.
Thank you.
All right, thanks.